In this class, we're going to talk about continent urinary diversions to include both abdominal reservoirs managed by catheterization and orthotopic neobladder connected to the urethra and controlled by the patient's own sphincter mechanism. If you have already watched the video on continent fecal diversions, you're going to hear a lot of the same concepts because the concepts are exactly the same. Continent fecal diversions, we're dealing with stool. Continent urinary diversions, we're dealing with urine. But the basic construction of both the abdominal reservoirs and the pelvic reservoirs very comparable, and a lot of the management's exactly the same. So, in looking at a continent urinary diversion, your goal is essentially to replicate the normal lower urinary tract. So you think normally we have a bladder that is low pressure, high volume, that effectively stores 300 to 600 cc's of urine at a time. We definitely need that. If we're going to create a continent urinary diversion, our reservoir, the reservoir we construct, has to provide adequate capacity at low pressure so that there's no back pressure on the kidney. So first of all, we need a stretchy, low pressure reservoir. The second thing we need is we need anti-reflux protection. Now in the native bladder, of course, the ureters enter the bladder through the trigonal muscle. They enter at an oblique angle, which helps to prevent ascending bacteria. And when the bladder contracts, the trigonal muscle also contracts, seals the ureters, and prevents any reflux of urine up the ureters. So if we are going to replace this bladder with a substitute reservoir, that substitute reservoir has to provide protection against reflux, has to minimize the risk of bacteria ascending the ureters into the renal pelvis. And finally, if it's going to be a continent urinary diversion, there has to be a continence mechanism, something that holds the urine in the reservoir until we pass the catheter. So let's talk about people who are candidates for continent urinary diversions. What are the criteria? What would be the contraindications? First of all, the patient has to understand that he or she will need to pass a catheter into the reservoir to drain the urine at least every 3 to 4 hours and PRN, and that will be a lifelong requirement. Now, when you talk to patients about catheterizing a reservoir, they're frequently concerned about pain because most of them have had a urethral catheterization that was uncomfortable. So you want to explain to them that they will not be passing the catheter through the urethra, they'll be passing the catheter through an opening made out of bowel, and that the bowel has no nerve endings that are sensitive to touch. So the catheterization procedure will not be uncomfortable in any way. They also need to understand that the catheterization procedure is very simple. Again, if they've been catheterized in the past, it was a sterile procedure. They associate it with PrEP solution and gloves and sterile field. And you want to explain to them that no, this is a clean procedure. It's as simple as this. You walk into the lavatory on an airplane. You wash your hands. You get out your clean catheter. You slide your clean catheter through the stoma on your abdominal wall, drain it into the toilet, take the catheter out, wash it, dry it, store it dry. Very simple procedure. It can be done anywhere. So the second thing is we need to be sure that the patient has no pre-existing problems with either renal failure or liver failure, because we're creating the reservoir out of bowel. The urine will sit in the reservoir for several hours. There is some risk of electrolyte reabsorption from the urine, and you need healthy kidneys and healthy liver to be able to handle any mild metabolic complications. And finally, we have to realize that patients who have had previous radiation to the abdomen may not be good candidates for this procedure. Sometimes the surgeon will get in there and say, no, the patient's not a good candidate for a continent diversion. I had to do an ileal conduit. So patients need to know that even if they elect a continent urinary diversion, they sign the consent for that, that when the surgeon gets in there, he has to make the final decision as to whether or not that's the best procedure for the patient. So we just always caution patients to realize that if the surgeon gets into the abdominal cavity and determines that it is not safe to do a continent urinary diversion, that the patient will have an ileal conduit instead and will wear a pouch instead. In actuality, that rarely happens, but patients need to know that it's a possibility. So in talking to patients preoperatively, what are the key points? Well, throughout this module, we've talked a lot about informed consent. And we've said whenever you talk to a patient about any surgical procedure, you basically have two goals. You want them to understand the procedure that's going to be done. You want them to understand the implications of what is being done. So for patients with standard diversions, we want them to understand that the bowel will be connected to the abdominal wall and that they will wear a pouch to drain either stool or urine. For a patient with a continent diversion, we want them to understand that an internal reservoir will be constructed, typically from loops of bowel, that reservoir will be connected to the abdominal wall, that there will be a small opening on the abdominal wall, what we call a stoma. We want them to understand that between the opening on the abdominal wall and the internal reservoir, there will be some kind of one-way continence mechanism. So it might be a naturally occurring valve, it might be an intussusception created by the surgeon. There's a lot of different ways to create continence between the stoma and the reservoir. Because of that continence mechanism, and because the reservoir itself has no contractility, the only way to drain the reservoir is to pass a catheter through the stoma into the reservoir. So you have a non-contractile reservoir that supports continence. You have some kind of one-way path between the abdominal stoma and the reservoir. This also supports continence. That means that you have to pass the catheter to open up the one-way path to drain urine out of the reservoir. This has to be done every 3 to 4 hours and PRN for life. We want them to also understand that if this procedure is being done because of bladder cancer, that there is the potential for sexual dysfunction. The vast majority of our patients do have urinary diversions as a result of bladder cancer, and most of those patients are men. So we want our male patients to understand that if the surgical procedure involves cystoprostatectomy, removal of the prostate gland eliminates seminal fluid and eliminates the potential for ejaculation. We want them to understand that the nerves controlling erection pass through the prostatic capsule, that the surgeon will do everything possible to protect those nerves, to spare those nerves, that the nerves will be swollen and bruised and that it will take 6 to 9 months for those nerves to recover. And they need to understand that we can't absolutely guarantee that erectile function will be restored. However, we should explain that should there be any long-term loss of erection, we have a number of treatment methods available. And of course, we want them to know no loss of sensation, no loss of potential for orgasm. So informed consent for a male patient undergoing continent urinary diversion and cystoprostatectomy has to include a discussion of the continent urinary diversion procedure, the lifelong requirement for in and out catheterization, and the potential for sexual dysfunction. For women who have bladder cancer and are having the bladder removed, there is the potential for dyspareunia, for pain with intercourse, because they also will remove most of the urethra or all of the urethra, and that can cause distortion of the anterior vaginal wall. So with both male and female patients, we need to follow up with them and determine what has happened in terms of sexual function and be prepared to counsel them postoperatively. Once we make sure that the patient understands what's going to be done, why, once we make sure they understand the implications, in and out catheterization for the rest of their lives, potential for sexual dysfunction, then we want to stop and ask, what questions do you have? What concerns do you have about living with a continent diversion? What questions and concerns do you have about doing that in and out catheterization? Do you have questions and concerns about the potential for sexual dysfunction? And you focus your discussion on their concerns. So always two goals: informed consent and address the patient's issues. And then we'll mark the stomacide. Now, as you see on the handout online or in your hard copy module, when you're marking a stomacide for a continent diversion, they're not going to be wearing a pouch. So you have different goals. Continent diversions are located in the right lower quadrant of the abdomen, so you're going to mark the stomacide on the right lower quadrant. It should be within the rectus muscle just to give support, and it should be in a site that's pretty easily visualized and accessed by the patient. But the requirements are not nearly as strict as they are if you're marking for a standard diversion where they have to wear a pouch. Okay, now we're going to talk about different types of reservoirs. And the first one you need to spend very little time on, because this essentially is a procedure of the past. But because patients show up in our clinics and our hospitals who have had procedures done many years ago, we did include this in your material so that you would be able to access it to look it up. Ureterosigmoidostomy was actually done on a number of patients during the 40s, 50s, 60s, and into the 70s. I even had a patient who had this done in a teaching hospital in the 80s. Here's the concept. If you have a patient who requires removal of the bladder, simply connect the ureters to the sigmoid colon. Now, I'm sure when they came up with this idea, it seemed brilliant, because what they were thinking is you already have the rectum, which serves as a reservoir. You already have the anal sphincters, which provide continence. So why don't we just connect the ureters into the sigmoid colon, let the urine drain into the rectosigmoid, and allow the anal sphincters to control elimination of both stool and urine. And you're probably sitting there thinking, that sounds like a terrible idea. And you're right, it did turn out to be a terrible idea. At the time they came up with it, it seemed pretty smart to the people who came up with it because it didn't involve a stoma or a pouch. But there were so many negatives that essentially this is no longer done. Probably most of the negatives are running through your head right now. Wouldn't you have a high risk of infection? Yes, because you've connected the urinary tract to the GI tract. If you don't master the angle at which the ureters are implanted into the sigmoid colon, then you'll have free reflux of stool and bacteria up into the renal pelvis. Even if you do a good job of angling the ureters, those bacteria are going to be able to migrate up the ureters into the renal pelvis. So significant instance of urinary tract infection. Also, you're draining urine, you're delivering urine to the rectosigmoid. The rectosigmoid is lined with mucosa, so there's a significant risk of electrolyte reabsorption and metabolic abnormalities, and actually a number of patients who had this procedure did develop electrolyte abnormalities. Third big issue is, what about incontinence? If you dump 2 liters of urine into the rectosigmoid every day, look what that does to your output. It's like having chronic diarrhea. So patients sometimes complained of diarrhea. That's exactly what happened to our patient who had that done. After 1 year, he came back and demanded an ileal conduit because he said he had had nonstop problems with control, with incontinence. He had not been able to go back to work. He had not gone back to church. He wasn't doing anything. So incontinence, infection, metabolic issues, But the most significant issue was an increased incidence of cancer at the ureterosigmoid anastomosis, and it was a delayed response, so it didn't happen immediately. But about 20 years after they started doing this procedure, they started noting a marked increase in sigmoid malignancies among this atypical group of patients. Why were they developing cancer? And it turns out that the combination of urine and stool at an anastomotic line acts as a potent carcinogen. I remember having a young guy who came in. He had had this procedure done when he was a child because of some birth defects. When he came to us, I think he was like 29, and he had developed an obstructing cancer at the anastomosis. He ended up with an emergency colostomy, an emergency ileal conduit, aggressive radiation chemo surgery, and he still died within a year. So that was the tipping point. Once they identified the increased incidence of cancer, most centers stopped doing this procedure. So that's why I say it's basically considered to be a procedure of the past. We put it in only because you might have a patient who had it done many years ago. But you do not need to study any of the details, just know the complications associated with ureterosigmoidostomy. The cochurostomy was done a lot during the 60s and 70s. Let me change that. Really not so much the 60s, more the late 70s and the 80s, the cochurostomy. And of course, as you probably have already figured out, it was developed by Dr. Nils Koch, the Swedish surgeon who developed the Koch ileostomy. So he took that basic concept of the Koch ileostomy and expanded it and modified it to create the Koch urostomy. Now I want to go through the critical elements. That's what you always want to think about. Whatever type of continent urinary diversion your patient's having done, you should know how are they creating the reservoir, how are they providing reflux protection, and how are they providing for continence. If you start working with a surgeon who's doing a procedure you've never even heard of, you want to sit down and ask that surgeon, explain to me how you create the reservoir. Explain to me how you provide reflux protection. Explain to me how you provide for continence. And then you'll have a very good understanding of what's been done and what to say to the patient. So with the cochurostomy, the reservoir is constructed from loops of ileum that are opened and reconfigured to form a pouch, just like we talked about with the cochleostomy. So you see you have several loops of bowel, or two major loops of bowel that have been opened and then reconfigured, and you're going to end up with a pouch formation. So reservoir is constructed out of ileum. The ileum is reconfigured to form a non-contractile pouch. What about reflux protection? Well, if you look right here, you can see that you have intussusception between the little segment of ileum to which the ureters are connected and the reservoir. So you have a one-way street or one-way path leading into the reservoir. So the ureters are connected to this little ileal segment, peristalsis in the ureters, peristalsis in this little ureteral segment. Then the urine flows through this one-way path and is trapped in the reservoir. So an intussusception at the proximal end between the ureteral segment to which the ureters are attached and the reservoir. What about continence? Exactly the same as with the cochleostomy, and that is intussusception between the abdominal stoma and the reservoir, creating a one-way path into the reservoir. So you have two intussusceptions creating one-way streets or one-way paths into the reservoir. The urine flows through the proximal one-way street and is caught in the reservoir until the patient passes the catheter through the second one-way street to drain the urine out. Notice that everything is constructed from the terminal ileum. The reservoir, the anti-reflux mechanism, and the continence mechanism. You end up using a significant amount of the terminal ileum. Usually takes about 75 centimeters to make the reservoir, plus both intussusceptions, plus the little inlet section to which the ureters are connected. And that means that any patient who has a coke urostomy is going to be B12 dependent for life. This was the first modern continent urinary diversion. But as you can see, is technically challenging to construct this reservoir with the two intussusceptions with the abdominal stoma and the ureteral inlet, and you create B12 dependency. So this is rarely done at this point in time. However, again, some surgeons might still be doing this, and there are certainly patients out there who had this procedure done, so you just want to know the basics of the coke urostomy. How did you make the reservoir? Out of ileum. How did you provide for reflux protection? Intussusception between the ureteral intake point and the reservoir. How did you create continence? Intussusception between the stoma and the reservoir. What do you have to know? These patients are B12 dependent for life. Now, how do we manage these patients post-op? Just as we said when we talked about continent fecal diversions, when you're talking about continent urinary diversions, you have to think about early post-op, when the reservoir is healing and the continence mechanism is healing, and then you think about long-term. So early post-op for a coke urostomy, you have a newly created reservoir. You have your ureters that are connected to the little section of ileum that you can't see. And then you have your abdominal stoma. You've got three major goals in managing these patients early post-op. First of all, you know you have multiple suture lines in that newly created reservoir. You want to prevent premature distension of the reservoir, because if the reservoir distends before those suture lines have healed, you'll get extravasation of urine out into the abdominal cavity. So how do we prevent premature distension of this newly formed reservoir? We place an indwelling catheter and we keep the reservoir drained. That catheter is typically placed through the stoma, through the intussusception or nipple valve into the reservoir. In this depiction, they have the balloon inflated, but in reality, most of the time we don't inflate the balloon. We just stabilize the catheter. It's very safe to pass the catheter through that continence mechanism, because the continence mechanism is nothing more than intussusception of the bowel on itself. So you've just created a double layer of bowel, just as we looked at yesterday, or whatever day you looked at or you viewed the video on continent fecal diversions. Let me show you. So again, when you look at creating continence via intussusception, you're pulling the bowel back on itself, so you have a double layer of bowel. Because the bowel is very muscular, and because the ileum is a very narrow section, you end up with the bowel being collapsed on itself. It's surrounded by a non-contractile reservoir, so no way the urine's going to track through here. In order to drain the urine out, you're going to have to pass a catheter through the stoma, through the intussusception into the reservoir. So we want to protect the newly created pouch with an indwelling catheter. We want to prevent in and out catheterization. We don't want somebody coming in every hour and putting a catheter into the reservoir to drain the urine out, because if people came in, put the catheter in, took it out, put it in, took it out, put it in, took it out, they're going to be creating a lot of drag on this newly created continence mechanism, this intussusception, and they could disrupt the intussusception. So instead, we want to put a catheter in, and we want to leave it in. I should have brought my catheter, and I didn't, so you're going to have to imagine. Here, I'll put this in as our catheter. So the catheter is in and it stays in. That does two things. It keeps the reservoir decompressed and it protects the healing continence mechanism, that intussusception. Obviously, it's very important to keep this catheter patent, so we're going to be irrigating, and most agencies, they irrigate every 2 hours and PRN. Then the last thing we have to do is we have to protect the ureteral anastomoses. So go back to the things we talked about when we were talking about management of patients who had an ileal conduit. And we talked about the fact that the ureters are very narrow structures. They're like 1/4 inch in diameter. And you have disconnected the ureters from the bladder. You have connected the ureters to this reservoir, to the little inlet portion that feeds into the reservoir. That requires a lot of manipulation of that very narrow structure. When you manipulate the ureters, you're going to get edema. You're then connecting the ureters to a section of bowel where you have mucus production. You're going to have oozing of blood because of the surgical procedure, and it would be very easy to literally occlude the ureteral channel. That would create back pressure on the kidneys, and you would get anastomotic breakdown, urine leaking out into the abdominal cavity. So you will notice that whenever ureters are manipulated during a surgical procedure, the surgeon always places a stent all the way from the abdominal wall up the ureters into the renal pelvis, just to keep that pathway open until the edema resolves and the anastomosis is well healed. So here you see the ureters, here you see the stents feeding into the ureters and going up to the renal pelvis. So the patient comes back from surgery, of course. The last phase in the surgical procedure is to literally close the reservoir. They come back from surgery, they'll have the reservoir catheter, and they'll have the stents. Now let's talk about long-term management. So short-term, it's all about keeping the catheter patent, monitoring the stents to be sure that they don't get pulled out of position so that those anastomoses are protected. As you saw in the previous slide, typically the ureteral stents are removed after about 7 to 10 days. Some urologists might leave them in for 14 days. So now let's talk about long-term. At about 10 to 14 days post-op, the surgeon will usually order a pouchogram to determine whether or not the suture lines are well healed. So basically what they do is they instill contrast through the reservoir catheter, clamp the catheter so that the reservoir starts to distend. They're looking for any evidence of leakage through those suture lines, any evidence of extravasation. If they see any evidence of extravasation, they're going to immediately drain the reservoir and they're going to leave the catheter in position. However, if the pouchogram shows that the reservoir is well healed, there is no leakage, no extravasation, then they'll remove the catheter and we'll start teaching the patient in and out catheterization. We take the catheter out. Now the reservoir will fill and the patient will need to routinely go in, pass the catheter, drain the reservoir, remove the catheter. Wait 1 to 2 hours, pass the catheter, drain the reservoir, remove the catheter. Just like we talked about with the continent ileostomy. You start out with a relatively small reservoir, so most surgeons have their patients drain the reservoir every 1 to 2 hours during the day and every 2 to 3 hours at night for the first couple of weeks, gradually lengthening the interval. What we want you to know is what's the average long-term interval, and on average, patients will need to drain the reservoir every 3 to 4 hours and PRN. How hard is it? It's much easier to catheterize a continent urinary diversion than it is to catheterize a continent fecal diversion. because you can use a small bore catheter. You can use a 14 French, a 16 French. You could use a 12 French if you had trouble passing the 14 or 16. Because you're not draining stool, you're only draining urine and a little bit of mucus. So remember when we first started doing continent urinary diversions, after we had already been doing continent fecal diversions, I was so used to working with those 34 French catheters, and then I had a 14, and it just slid right in. It was so easy. So it's usually very easy to teach patients how to do in and out catheterization. The entry point is very clear. Then you just teach them to use that twirling motion so that they feel their way through the continence mechanism until urine starts to drain. Drain the reservoir, remove the catheter. You emphasize clean technique, clean hands, clean catheter. It's not a sterile procedure. Now we talked, when we talked about continent fecal diversions, we talked about the controversies surrounding routine irrigation. Those same controversies apply to routine irrigation of a continent urinary diversion. When we first started doing continent urinary diversions, a lot of surgeons did teach their patients to irrigate the reservoir until clear once or twice a day, thinking it would be beneficial to remove all residual mucus. However, as we have discussed, if you constantly flush out a reservoir, you can actually be flushing out the good bacteria that help to keep the bowel wall healthy. So most clinicians focus more on fluid intake. They talk to patients about the importance of drinking adequate volumes of fluid and drinking throughout the day. Some patients believe that drinking cranberry juice or taking cranberry capsules helps to thin the mucus. That's not evidence-based, that's anecdotal in nature. But definitely, if they're drinking plenty of fluids, it keeps the mucus thinned out so that when they pass in the 14 or 16 French catheter, most of that mucus will drain out along with the urine. So whether or not you teach your patient to irrigate the reservoir is going to be dictated in large part by the surgeon's philosophy and by the discussions held between you and the surgeon, and hopefully by emerging evidence. We definitely need studies. Right now we don't have studies to guide this area of practice. We have opinions, so you know how that goes. So routine irrigation possibly, not routinely. Definitely a strong focus on fluid intake, critical. Because as long as the patient's drinking adequate volumes of fluid, they're going to constantly make urine that will tend to flush out any bacteria, and it will thin out the mucus. And then they need to know to protect the abdominal stoma with a protective pad so that it's not exposed to trauma from clothing and so that the skin is protected from mucus. Okay, let's go to the next type of reservoir, and this is actually the most commonly performed reservoir at present, the Indiana reservoir. Now there are variations on this. There's a Miami pouch, a Florida pouch, and the main difference in those reservoirs and the Indiana reservoir uses the cecum, and the Miami and Florida use the entire ascending colon. But other than that, essentially the same. So with the Indiana reservoir, they use the cecum to be the holding area for urine. And I want you to notice, so here's the cecum, here's this little bit of terminal ileum that's going to be used to create the stoma and to provide continence. They selected the cecum because it's a non-essential area of the colon, and it's the most distensible area of the colon, so it stretches readily. However, the cecum does retain peristaltic function. So if the cecum over-distends, it has the potential to contract and to force urine out. Because of that, they don't use the cecum as is. They modify the cecum to turn it into a non-contractile reservoir, a passive holding area for urine. How do they do that? Well, look at the top. You start out with the cecum intact. Then you see that open the anterior wall of the cecum, And then you see that they have folded it down so that instead of a tubular structure, you now have a pouch structure. In so doing, they've interrupted the muscle fibers and they've eliminated contractility. So they've turned it into a passive reservoir. So what's the reservoir in Indiana pouch? The cecum with muscle fibers interrupted to create a non-contractile reservoir. What about anti-reflux protection? What they do is they tunnel the ureters along those thick muscle bands in the colon known as the tinea coli. And what they found was that when they tunnel the ureters along the tinea coli, there's enough resistance to prevent reflux. However, the peristalsis in the ureters is sufficient to assure normal delivery of urine. So that's actually been very effective in the patients who have had this procedure done, tunneling the ureters along the tinea coli. That's your anti-reflux protection. Now, what about the continence mechanism? Well, none of these slides show it as clearly as I would like for them to, but if you remember your anatomy, you have a naturally occurring one-way valve between the ileum and the cecum. It's called the ileocecal valve, and it's literally like a one-way swinging door that goes from the small bowel into the colon and allows contents to pass from the small bowel to the colon, but prevents backflow from the colon into the small bowel. So here's this naturally occurring one-way valve located between the ileum and the cecum. That's your primary continence mechanism. Now, to strengthen that continence mechanism, what the surgeon does during surgery, he will pass a narrow tube through the section of ileum. So this is the section of ileum that's going to create the stoma, and that's also going to create additional support for the continence mechanism. So you see this suture line here? What they're trying to show you is that the surgeon will pass a narrow catheter into the ileum, and then he will pleat or taper the ileum around that catheter. So you take the ileum from a 1-inch structure to about a 1/4-inch structure, which means you create a very narrow hallway, a tight sleeve. And at the end of that narrow hallway, you have the ileocecal valve. So continence is provided by a combination of that naturally occurring valve and surgical tapering of that ileal sleeve. So you have a narrow channel, a narrow hallway, and a swinging door at the end. So in the end, you have your reservoir, you have anti-reflux protection created by tunneling the ureters. You have continence provided by this one-way valve that you can't see, and by surgical tapering of the ileum. So here it is actually in place. Here's your stoma. Your one-way valve is right in here. You've tapered the ileum down. The ureters have been tunneled into the reservoir. So let's talk about early post-op care. Aren't our goals going to be exactly the same? We've got a newly created reservoir. We have manipulated our ureters, so we'll need protection of the ureteral anastomoses. You have a naturally occurring one-way valve, but a newly tapered ileum, so you need protection of your continence mechanism. You don't want to be putting things in and out, in and out, in and out. So management early post-op is going to sound very much the same as what we said for the patient with a cochurostomy. Specifically, you want to prevent distension of the reservoir. How do we do that? We place an indwelling catheter. We irrigate that catheter as needed to keep it patent. Now there is one difference. You see on the slide it says the indwelling catheter is placed through an abdominal stab wound. Now I'm trying to show that here. You've got your reservoir catheter going into the reservoir via stab wound. These are your stents. But you can probably see it more clearly here. So here's your stoma with the little stent sticking out. Here's your reservoir catheter placed through a stab wound into the reservoir. why do they not place the reservoir catheter through the stoma? Why do they place it through a stab wound? Think about the fact that that ileocecal valve is a naturally occurring valve. If I put a fairly large bore catheter through that ileocecal valve and hold it open for somewhere between 7 and 14 days, I can cause enough inflammation and trauma to the ileocecal valve to cause scar tissue formation, which would alter its function. So they typically put the reservoir catheter in through a stab wound so that there's no interference with the ileocecal valve. You're going to protect your continence mechanism. As we've said, no in and out catheterizations until the narrow tapered ileum has healed, and don't put your reservoir catheter through the ileocecal valve. So protect the ileocecal valve and allow that surgically tapered ileal sleeve to heal before you allow the patient to do in and out catheterizations. And of course, you're going to protect your ureteral anastomoses. You're going to have stents placed through the ureters all the way up to the renal pelvis. Some surgeons will bring the stents out through the stoma because they're very narrow, and so they're very unlikely to traumatize the ileocecal valve. Some surgeons bring the stents out right beside the reservoir catheter, and they don't have anything passing through the ileocecal valve. So, to some extent, placement of your drainage tubes will be affected by surgeon preference. Here are the things you need to know. You always have a reservoir catheter, and your goal during the first 2 weeks is to keep that reservoir catheter patent. You never do in and out catheterizations for the cochleostomy, for the Indiana reservoir, for any continent diversion. You never do in and out catheterizations during the first few weeks. You wait until the reservoir is healed and ready to distend. You wait till the continence mechanism has healed and is ready for in and out catheterizations. You always have ureteral stents. You always have a reservoir catheter. You've always got to protect your continence mechanism, and you've always got to protect your ureters. The specifics, how they place the catheter, how long they leave it in, whether the stents come out through the stoma or through the abdominal wall, yes, those will differ based on surgeon preference. The bottom line concepts remain the same, so focus on those. Okay, long-term management of an Indiana reservoir. So remember that the reservoir catheter is placed through an abdominal stab wound. When they do the pouchogram to determine has the reservoir healed and is there presence to rule out any leakage. So they put the dye in, allow the reservoir to distend, make sure that there's no leakage of contrast. Okay, reservoir is healed. We're ready to teach the patient in and out catheterization. With an Indiana reservoir, your reservoir catheter is placed through a stab wound. So you can actually clamp the reservoir catheter but leave it in place and start teaching the patient in and out catheterization. The reservoir catheter is just a backup, okay? So it's there but it's clamped, and you're letting the reservoir fill, and the patient's putting the catheter in, draining the reservoir, pulling the catheter out, let it fill, put the catheter in, drain it out. So as we've talked about before, with in and out catheterization, you gradually lengthen the interval because you're gradually stretching the reservoir. Most of the time they have them start out with catheterization every 1 to 2 hours because usually your reservoir holds about 60 to 75 at baseline. So they'll start out with every 1 to 2 hours, then every 2 to 3 hours, then every 3 to 4 hours. Most patients long-term catheterize about every 4 hours, but also PRN, because if you go out to dinner, you're sitting there with friends, you're drinking more fluid than normal, or you're drinking wine with dinner, you're going to have more urine output. You're going to need to catheterize more often. They do have the sensation of filling. It's not the same as a full bladder sensation, but they can definitely tell when their reservoir is full. They need to know to get up and go drain. We've already talked about Small catheter, 14 to 16 French, clean technique, clean hands, clean catheter. Once the patient's comfortable with doing in and out catheterizations, they'll pull the reservoir catheter. They might have a little bit of leakage through that tract for the first 12 to 24 hours after they pull the catheter. It will stop on its own. Fluid intake, very, very important. We've already discussed the issues related to routine irrigation. Is it helpful? Is it not helpful? I basically want you to understand the controversies surrounding routine irrigation. I want you to understand why some surgeons recommend it, because they believe that it's helpful to eliminate any residual mucus. They're afraid that mucus will be retained, and that retained mucus will support bacterial growth or will act as a nidus for stone formation. Other surgeons do not want patients to irrigate the reservoir because they're concerned that they will actually be disrupting the normal flora and increasing the risk of an inflammatory reaction, pouchitis. At this point, we lack data to say which approach is best. So I want you to know it's controversial. I want you to know why. You will work with your surgeons to determine how to manage your patients. But for all patients, natural irrigation is very important. Adequate fluid intake to keep the urine dilute, to constantly flush bacteria, and to thin the mucus. So major focus on fluid intake, and of course, again, a protective pad over the stomach. There's another type of reservoir I want you to know about. It's called the Mitrofanov. This is frequently done in the pediatric population. It's also a procedure that is used to create continent diversions in adults with neurogenic bladder. It started out as a concept, and now you also have the Mitrofanov procedure. But the concept is this: you can create a low pressure reservoir from any section of bowel, or you can create a low pressure reservoir by enlarging the patient's own bladder if they have a neurogenic bladder. And you have to create a catheterizable channel, and you can use a variety of structures to create a catheterizable channel. The example I'm giving you here is the most common Mitrofanov procedure, and it's also known as an appendicovesicostomy, which is a very commonly performed procedure for children with neurogenic bladder, meaning they have no bladder control, and adults with neurogenic bladder. What's involved? You have your reservoir, you have the bladder. Neurogenic bladder is a non-malignant condition, so yes, you can use the bladder as a reservoir. Many patients who have neurogenic bladder have relatively small volume, high pressure bladders. So you need to modify the bladder so that it is an effective reservoir. In those cases, they'll start out with bladder augmentation. So they'll open the bladder, and then they'll attach a piece of bowel. In attaching a piece of bowel, you do two things. You physically enlarge the bladder, and you interrupt those muscle fibers so you eliminate contractility. So you turn it into a much more effective reservoir. Okay, so now you have your augmented bladder. Now you need to create a catheterizable channel. Many times they use the appendix, they disconnect the appendix, and they attach the appendix to the bladder, and then bring the appendix out onto the abdominal wall, frequently right around the umbilicus. If necessary, if they're leaking through the urethra, they'll close the urethra. So you're using your bladder as your reservoir. The bladder has built-in anti-reflux protection, so you don't have to do anything about that. So you've got your reservoir, and you've got your catheterizable channel that you created by taking the appendix and connecting it to the bladder on one end and to the abdominal wall on the other end. If the patient's already had an appendectomy and that's not available, you can take a small section of bowel and taper it down so that it's a very narrow tube with high compression force so that you don't get leakage. Connect it to the bladder and to the abdominal wall. As the bladder fills, it creates pressure that helps to keep this pathway closed. To drain, the patient simply passes the catheter through the opening in the abdominal wall into the reservoir. So a lot of times with these kids, they bring it out right at the umbilicus. They think it's really cool because they can pass the catheter through their belly button and drain urine out of their bladder. And I have to tell you that the first adult that I saw with an appendicovesicostomy fooled me totally. She had had it done for neurogenic bladder. They asked me to go in, catheterize her stoma. I asked for the chart, they're like, we'll get it for you, just please go get our specimen. I'm like, okay. So I went in to get the specimen. Well, she's already on the table, she's draped, and I don't see any stoma. So you know how when you walk into a room and you realize you're in the wrong room and you make all these apologies and back out. So I go back out and I told the nurse, I'm like, she doesn't have a stoma. So they're like, okay, well, let's look at the chart. I thought they said she had a stoma. So we pulled her chart, and sure enough, she had a metrophenol, an appendicovesicostomy. And the surgeon had brought the appendix out at the umbilicus and had done a skin graft over the opening of the appendix, so it looked exactly like the belly button. So when I went back in, I said, you know, I was just in here. She's like, I know. I'm like, well, let me tell you what I came in for, let me tell you why I left. She loved it because it's the ultimate in camouflage. Nobody even knows you have a stoma until you pass the catheter. So metrophenol just means, look around. What do you have you can use as a reservoir? Can you use the bladder itself? Yes, you can. If the patient has neurogenic bladder, do you need to enlarge it? Do so. What can you use as a catheterizable channel? Does the patient still have an appendix? Use that. Oh, the appendix is already gone? Okay, take another little piece of bowel, roll it up into a narrow tube, use that. So I want you to know that term. Now we'll quickly go through management. We've actually covered most of this. Intubation, we've talked about catheter size, that it's clean technique, not sterile. You lubricate, you insert the catheter, you don't force it, just like we've talked about in previous classes. Then they'll wash and dry the catheter and store it dry. So most people have a Ziploc bag and they put the catheter in the Ziploc bag and just keep it in their purse or in their jacket pocket. Very important for patients to know, catheterize on schedule and catheterize whenever you feel full. As the reservoir fills, it puts more and more pressure against the continence mechanism, either the ileocecal valve or that intussusceptive section of the bowel, and it becomes more and more difficult to catheterize. So it's very important for them to know, don't let your reservoir overfill. If you start feeling full, go catheterize. If it's time, go catheterize. They definitely need to have medic alert, because you think what would happen if they were in an accident. They show up in the emergency room. They have this little covering over a small opening on the abdominal wall. Nobody thinks anything about that. Nobody knows what that is. What's one of the first things they do when they bring you into the emergency department if you're a trauma victim and you're unresponsive? They put a catheter in you so that they can monitor urine output, and they start fluids. So when they put the catheter in, all they're going to get is bloody drainage, and now they're loading you up with fluids. Your reservoir is filling, no one knows. So absolutely essential for them to have medic alert that alerts everyone to the fact that they have a continent urinary diversion, that a catheter has to be inserted through that abdominal stoma to drain the urine. And finally, they have to know, don't go anywhere without your catheter. Because if you're somewhere without your catheter, you'll have no way to drain the reservoir. And if you get full, you're stuck. So I always tell people, before you had this surgery, would you ever have gone anywhere without your urethra? Well, no, of course not, because first of all, it's attached to you. But also because you have to have your urethra to be able to empty your bladder. Same thing with your catheter. Don't go anywhere without your catheter. You don't know what's going to happen. Yes, you intended just to run to the store. You thought you'd be gone 15 minutes. There was a huge accident. Don't go anywhere without your catheter. Because if so, you could get caught in a very difficult situation with increasing distension of your reservoir and no way to drain. Difficult intubation, we talked about in the class on continent fecal diversions, much less likely to happen to a patient with a continent urinary diversion because they use much smaller catheters. But we've already talked about the importance of catheterizing on schedule. If they do have problems passing the catheter, they can use a smaller catheter. They can try a different position. We want them to recognize the signs of urinary tract infection, which are cloudy urine, malodorous urine, just feeling bad in general, low-grade fever, flank pain. We want them to know to promptly report any signs of urinary tract infection so that we can culture them and get them on antibiotics. They should always have travel kits, so people who are still working should have extra catheters in their desk drawer. Anytime people travel anywhere, they need to keep a catheter literally in their pocket, in their purse, something that goes everywhere they go. What about peristomal skin care? It's very rare for them to have urinary leakage, but they will have mucus production from the stoma itself. So they need to protect the peristomal skin. Some people routinely use skin prep, others routinely use a little bit of dimethicone barrier cream, and of course they need a protective cover over the stoma. What are the potential complications? Early anastomotic breakdown if we allow the reservoir to distend prematurely, if we don't do a good job of keeping that catheter patent until the reservoir is well healed. What would be the signs that we might be getting into anastomotic breakdown? They could have increasing pain, increasing abdominal distension because they're leaking urine out into the abdominal cavity. You could note increasing output through your surgical drains and through your surgical incision, and decreasing output through stents and reservoir catheter. Again, not common, but we're always on the alert. What about pouchitis? We have created a reservoir. We have urine and we have some mucus sitting in the reservoir. Could they develop an inflammatory process involving the reservoir? Yes, they could. But statistically, it is much less common with urinary reservoirs than it is with fecal reservoirs, which makes sense because bacterial counts are much higher with fecal reservoirs than with urinary reservoirs. Urinary reservoirs have very low bacterial counts. So we do not see nearly as much pouchitis among patients with continent urinary diversions. However, we're always aware that it could occur, so we do tell patients if you develop signs of tenderness, itching in the area of the pouch, increased mucus production, if you start noticing blood in your urine, if you're just not feeling well, anything, come in and let us check you out. UTI we've already talked about. Metabolic complications, there is the potential because urine sits in that reservoir that is lined with mucosa. There is the potential to reabsorb electrolytes from the urine. They can reabsorb potassium, which could cause a very serious hyperkalemia. They tend to lose bicarb, so they can develop metabolic acidosis. Bottom line, what we need to teach our patients is drain on schedule, keep your urine dilute, pay attention to how you feel. If you start feeling badly, if you start feeling weak, if you start having problems with nausea, if you have problems with abdominal pain or cramping, anything seems abnormal, come in and let us check you out. Most patients do not develop problems with metabolic abnormalities, but it is a possibility. In most centers, when patients go back for routine follow-up, they will check their electrolytes to make sure that everything is on track. Leakage is uncommon. If a patient is complaining of leakage, my first intervention is typically tell them to keep a chart, write down what time they catheterized, how much they get, write down their fluid intake, write down any episodes of leakage. That allows me to do initial troubleshooting. Are they allowing the reservoir to overfill? Is that the issue? However, if it's persistent or severe, I'm going to refer them to the physician because we need to determine what's going on with the continence mechanism. Okay, we're not going to spend a lot of time on orthotopic neobladder. This is the newest option for patients who require cystectomy. It is to actually create a pelvic reservoir and anastomose it to the patient's own urethra. The reason we're going to spend limited time on this is that at this point in time, there are not that many centers that are doing orthotopic neobladders. And even in the centers that do orthotopic neobladders, WOC nurses may or may not be involved. But I definitely want you to know the basic concepts and the potential issues, because you may be asked to pre-op a patient who is electing an orthotopic neobladder, and you need to be able to explain the procedure, answer their questions, and explain potential problems that might occur with the orthotopic neobladder. So let me just define terms. Orthotopic means that you put the replacement organ in exactly the same position as the original organ. So when you see on a chart that a patient had an orthotopic renal transplant, it means that the transplanted kidney is, in exactly the same retroperitoneal position as the original kidney. Whereas most transplanted kidneys are floating free in the abdominal cavity. So orthotopic means that you've got a pelvic reservoir or neobladder that's connected to the patient's own sphincter. So you create the reservoir again from loops of bowel, typically small bowel. That's what they're showing you on the top slide, but I think it's easier to appreciate right here. The distal portion of the newly created reservoir is tapered so that you can anastomose it to the urethra. They have to realize that when they remove the bladder for cancer, they take out the bladder and they take out the proximal portion of the urethra, the bladder neck and the top part of the urethra. So when they create the orthotopic neobladder, the reservoir, they're going to taper the distal end of the reservoir so it can be connected to the residual urethra. The connection to the urethra is always done above the voluntary sphincter mechanism so that the patient retains voluntary control. That's very important. So what about continence? What about voiding? Two things contribute to continence. First of all, when you make this reservoir out of loops of bowel and you reconfigure those loops of bowel to form a pouch, what do you do to contractility? You eliminate it. So you have a non-contractile reservoir, so pretty much a passive storage area. The other thing that contributes to continence is the voluntary sphincter mechanism, which is always retained. And the vast majority of patients tell us that they are dry throughout the day when they're awake, alert, able to respond to any sensations of fullness with voluntary contraction of the sphincter. But what about voiding? Because in order to achieve continence, we created a non-contractile reservoir. How is the patient going to empty the reservoir? They have to relearn how to void. So they have to void by relaxing the voluntary sphincter, using the Valsalva maneuver to create downward pressure on the reservoir, on the neobladder, to empty. And some patients actually end up doing per-day abdominal or manual pressure over the reservoir to help empty. Who's a good candidate? Any patient who requires bladder removal and does not want a stoma would prefer to have an orthotopic neobladder. They started out doing them primarily in men. Now many surgeons are doing them in women as well. There are contraindications. In men, if the malignancy extends into the prostatic urethra, then you're going to have to remove all of that tissue. You're going to be encroaching on the voluntary sphincter. They would not be a good candidate. In women, you have a much shorter urethra. You need all of your continence elements. So if the tumor involves the distal portion of the bladder, the trigone, or the bladder neck, usually they would not do it in a woman. So talking to the patient preoperatively, we're right back to our basic concepts. We want them to know what's being done, why, what to expect, what are the potential management issues, and then we want to address their concerns. So what are the potential management issues? Well, first of all, there's the potential for leakage because you've removed the bladder neck, so you've removed part of the continence mechanism. That means that it's going to be very important for this patient to learn how to do pelvic muscle exercises correctly, and it's going to be important for them to do them routinely, post-operatively, in order to maintain normal sphincter tone, normal pelvic floor tone, in order to minimize the risk of leakage. Now, women are frequently somewhat familiar and comfortable with pelvic muscle exercises. We still need to check to be sure they're doing them correctly. Men frequently have no idea how to do pelvic muscle exercises. We have to teach them. And it's simple. You just teach them tighten as if you're trying not to pass gas, not to pass stool, not to pass urine. Hold it as tightly as you can for as long as you can. Relax for 10 seconds. Repeat. Men actually have an advantage in doing pelvic muscle exercises because when they do them correctly, they'll get scrotal lift. So they can literally stand in front of a mirror and go 1, 2, 3, and watch the lift. So they have to know that pelvic muscle exercises will be a critical element of post-op care. I also have to say to them, it's very common for patients to have nighttime leakage because when you fall asleep, your voluntary muscles relax, the urethral resistance drops, and you can get leakage through the urethra. For most patients, that's short term and improves dramatically over the first 3 to 6 months, but for some patients it's long term. They have to know this pre-op. We cannot guarantee that you will be completely dry. You might have leakage, especially at night. Most patients are dry during the daytime. If they're going to leak, it's typically at night. And I remember one of my patients, and when he came in, he said, and I knew him and his wife very well, he said, I want to report spousal abuse. So I'm like, okay, tell me what's going on. Well, what was going on was that the minute he fell asleep, he would start to leak. And you know how you're sitting and watching TV or watching a movie and you fall asleep? So his wife was constantly monitoring him. He should be like, Jim, are you awake? Jim, are you awake? Because she knew if he fell asleep, he'd be soaking wet. So he's like, I'm black and blue. The second potential issue is retention. Some patients empty very effectively with Valsalva, and they have very low PVRs. Other patients empty moderately well. They have mid-level PVRs, and they might need to catheterize once or twice a day. Occasionally, patients will not empty well at all, and they'll need to do intermittent catheterization multiple times a day. So the patient who signs up for this procedure needs to be prepared for the potential for nighttime leakage, at least short term, possibly long term. And they need to be prepared for the possibility of needing to catheterize at least once or twice a day, possibly more often. Some patients have no leakage and no problems emptying. That's the ideal outcome, and we've had a number of patients who had ideal outcomes. That's what we hope for everyone, but we can't guarantee it, and we need to be sure that they understand before they go into surgery that leakage issues are a possibility and retention is a possibility. Sexual dysfunction we've already covered, and of course addressing their concerns. Now, I'm not going to ask you any specific things about post-op care, but I will go over the major things during the early and late post-op period. I'll go through it briefly. Bottom line, if you start doing these in your agency, you're going to sit down with the surgeon who's doing it. You're going to find out about his or her routines, how you work together to give your patients the best outcomes. But what I want you to realize is that when they come back from surgery, they're going to have multiple catheters. So they'll have a reservoir catheter that is inserted through an abdominal stab wound to keep the reservoir decompressed until it's healed. They'll have stents, always you have stents going through the ureters and up to the kidneys. They'll have a urethral catheter because you have to support the anastomosis between the reservoir and the urethra. So they have both a Foley catheter and a reservoir catheter. And then they have the ureteral stents. The ureteral stents may be brought out right beside the reservoir catheter onto the abdominal wall, but frequently are brought out right alongside the urethral catheter, so that you've got the urethral catheter and these two little stents. Then you've got the reservoir catheter, then you've got your surgical drains. And of course, the goals are just what you know. Keep the reservoir decompressed until it's healed. Support the urethral anastomosis until it's healed. Support the ureteral anastomoses until they're healed. So the same things, we just keep saying the same things over and over again. Very important to tape the tube securely. You do not want disruption of that Foley catheter. You don't want disruption of the reservoir catheter or of the ureteral stents. Some agencies have very strict taping protocols. Bottom line, stabilize, secure your tubes, monitor your output. Typically what happens is about 7 to 10 days post-op, once you have good initial healing and the edema has subsided, they will pull the ureteral stents. They'll discontinue the surgical drains. They usually take out the stents and drains before the patient goes home. Not always, but typically. That's pretty much always the first thing to come out, the stents and the drains. The urethral catheter comes out next, usually about 2 to 4 weeks post-op, once the reservoir and the urethral anastomosis are well healed. So again, they've typically done a pouchogram to be sure that everything looks good, that you don't have extravasation anywhere. At that point, they can remove the urethral catheter. They usually leave the reservoir catheter in as backup, and I've been explaining to you why. So if I go back one, the stents would be gone, the urethral catheter's gone, the reservoir catheter's still in place and clamped. Now we're going to put the patient on a voiding trial. And what we're going to tell them is, okay, you're going to, all of your tubes are out now, you're going to clamp the reservoir catheter. In 2 hours, I want you to go and try to void. And usually we tell men initially just sit to void because you've got to concentrate on voiding. You're only a couple of weeks post-op, you're still weak, sit, so that you can concentrate on the Valsalva maneuver, relaxing the sphincter, Valsalva maneuver. Void into a hat so you can measure the amount you voided. Dump that, open the reservoir catheter and drain out anything from the reservoir catheter. That gives you a pretty good idea of your post-void residual. Keep a record. 8 a.m., I voided this much, I had this much post-void residual. 10 a.m., I voided this much, I had this much PVR. So they void, then they open the reservoir catheter, check residual, clamp the reservoir catheter, go 2 more hours. Once they can void effectively or they have mastered intermittent catheterization, you pull out the reservoir catheter. So the reservoir catheter is backup as long as they need it. Once they're voiding effectively or catheterizing effectively, the reservoir catheter can be removed. Long term, we're going to work with them on pelvic muscle exercises as well as strategies to empty effectively. Are there complications? Yes, there's always complications for every surgical procedure, but they are limited. perforation, but not typically, usually only if the reservoir is allowed to over-distend. So we talk to patients about the importance of voiding on schedule, doing intermittent catheterization if they're not able to empty. Metabolic complications we've talked about. They need to keep their appointments, have their lab work checked, report if they're feeling badly. Leakage we've talked about, incomplete emptying we've talked about. Yes, they can get a urinary tract infection. That's relatively uncommon, but again, if their urine looks bad, smells bad, if they feel bad, if they have suprapubic tenderness, yes, they need to come in. And bottom line, as we have increasing numbers of patients who are having this procedure done, we are gathering data about quality of life. Most patients report very good satisfaction and very good quality of life. What do I want you to focus on? I want you to know what orthotopic neobladder is. I want you to know the potential problems with orthotopic neobladder. Okay? Thank you very much.